Thank you very much, Roddy, and good morning, ladies and gentlemen. I'd like to thank Pauline for inviting me here today, although just at this moment I could cheerfully strangle her. And she asked me to speak to the theme, one of the themes of the conference in relation to mental health and well-being. And I felt it was a good opportunity then to talk to you about, in this country, the emergence of a clinical programme in relation to mental health and substance misuse. So I suppose the term dual diagnosis has been used, but the journey to developing the clinical programme has been very interesting over the years, both from the mental health point of view and from the substance misuse point of view in this country. Addiction services have gone to become the poor relation in relation to mental health services. And in substance use, alcohol has become the poor relation in relation to interventions and services around substance misuse. So to draw together these elements into the development of a clinical programme has been a journey. Well, what's been constant through the journey is the suffering and the ill health caused to individuals, and it's the individual is at the core of the dual diagnosis programme that we're developing. And as Brian has said in relation to our strategy, we have a very person-centred approach. And time and time again over the years, what struck me is that people come into services talk to being disenfranchised from mental health services, disenfranchised from addiction services because of the very fact that they may have a comorbid presentation. So in terms of a definition, it's the coexistence of mental health and substance misuse problems, including both drugs and alcohol. And it's important to mention drugs and alcohol because, as I say, alcohol did become the poor relation in relation to substance misuse development. Each disorder is chronic and relapsing. They have independent courses and are capable of influencing each other. And as Doug Selman from the New Zealand National Addiction Centre in 2010 said, it's somewhat unusual to encounter a person presenting to an outpatient addiction services with addiction problems alone. And he felt that it was the rule rather than the exception that they would have a comorbid mental health disorder. And as a psychiatrist working in substance misuse, this has been the key area that I've been interested in over the last 25 years. There's lots of research being carried out in relation to the prevalence of comorbidity. And this is one slide from the EMCDDA showing high incidence of personality difficulties, depression and anxiety disorders, and psychotic disorders. And the interaction between all of these can produce individuals who have very difficult presentations and very difficult courses in treatment. The implications of having a dual diagnosis would be that symptoms are exacerbated. Individuals with dual diagnosis often are non-compliant with treatment regimes or medications. Interactions between prescribed medications and illicit drugs are very common and can lead to people dropping out of treatment. There's clear evidence of increased relapse rates and severity, and also clear evidence of increased costs to services and the use of services, greater rates of admission to hospital, increased risks of violence, and increased risks of suicide and self-harm. We see increased rates of homelessness, and currently in Dublin, you may be aware that we have a very significant homeless crisis. Many of the people who are homeless do have substance misuse and mental health difficulties. There's increased risk of HIV and bloodborne viruses. The more complex intervention strategies are required to be developed for dual diagnosis. And I think what's often missed is that there's an increased burden on carers and family. And constantly people are coming up to me and telling me the story about their children and their loved ones who are unable to get access to treatment services. And the burden that this has put on them, looking after them in the home setting, has been very striking. There's rejection by the psychiatric services. No, your primary problem is drugs. Your primary problem is alcohol. We can't do anything for you. And this is somebody who's presenting suicidal. There's rejection by the drug services. Oh, well, that's depression. We can treat your drugs, but, you've got to go and get that depression treated before you're really going to be able to recover. People present with more positive and less negative symptoms. And what I mean by that is that they're more likely to have very florid symptoms in terms of hallucinations, rather than becoming just withdrawn into themselves. And there's greater complexity in diagnosis and assessment. One of the things which has complicated the issue of dual diagnosis, and particularly the issue of dual diagnosis in this country, has been the emergence of new psychoactive substances over the last 10 years. And I think the emergence of these new psychoactive substances have focused the mental health services into seeing that dual diagnosis is a real issue. As you know, they've been developed as legal alternatives to illicit drugs. And for addiction services, for drug services, they're dealing with different populations than they used to be dealing with. They're dealing with significant changes in drug use patterns of behaviour. What's clear is that these new psychoactive substances are much more potent, particularly in relation to mental health problems and in the development of mental health problems. Access to the drugs is also different. Internet shopping, including the darknet, but you don't have to go to the darknet to get new psychoactive substances. And home delivery by DHL to your door is commonplace now with new psychoactive substances. So this is an issue that addiction services have had to very quickly come to terms with. There's different markets, so they're sold as legal highs. They've got bright, attractive packaging, and they're sold in head shops and smart shops and online. And in 2010, we introduced legislation in this country. We're one of the first countries to introduce legislation to ban head shops. But unfortunately, the problem with new psychoactive substances hasn't gone away, and we see that people are accessing them through various different means. They're sold as research chemicals, and they're sold very clearly on the site when you go and buy them. This is not for human consumption. They're sold as food supplements, food or dietary supplements that can be sold in fitness shops or online. Designer drugs, they're passed off as drugs such as MDMA or heroin, and they're sold then on the illicit market by organised crime. And we're seeing more and more medicines diverted from patients or illegally imported. And I see in your pack today you've got information in relation to pregabalin. We have a significant problem in Dublin in relation to Lyrica misuse. And people who are misusing Lyrica find it very difficult to access services. If you look at the pattern of prescribing of Lyrica in this country over the last 5 years, it's become the third most reimbursed product under our GMS, or under our medicines reimbursement scheme. Everybody loves it. Surgeons, psychiatrists, GPs. You go in with a spray and you get Lyrica. You go in with anxiety, you get Lyrica. You go in with an odd presentation, you get Lyrica, because it's not a benzodiazepine. And yet people don't realise the fact that it causes very significant dependence and problems. So this is the packaging of the new psychoactive substances. If you look there, you see Spice Gold. It's a synthetic cannabinoid. For just a little bit less, you can get Spice Silver. And for a little bit more, you can get Spice Platinum. Scooby Snacks, described as potpourri. Most of the potpourri that I've bought doesn't come with a little pipe. And as I say, they've been identified as alternatives to illicit drugs. So traditionally, illicit drugs that you've been looking at have been cannabis, stimulants then, such as cocaine, amphetamines, and opioids, such as heroin. So instead of cannabis, you've got the synthetic cannabinoids, the spice products, and there's a particular problem in the prison system in relation to spice in the UK and also in Ireland. And earlier this year, the Irish Prison Service developed an information package in relation to new psychoactive substances. We work closely with them in relation to that. The stimulants, instead of cocaine and amphetamine, drugs such as cathinones, alpha PVP, we've had problems with that in relation to an increase in HIV transmission amongst homeless drug users injecting alpha PVP. Crystal meth, you've heard about that already today. And 2CP, we've had very significant problems associated with the 2C family of drugs. People may remember in Ireland we had a death associated with N-bomb, which was one of the 2C family, earlier last year, and the headlines that were generated in the media in relation to these drugs, it was unbelievable. Young person dies after a drug-induced rave party, you know, and this is sort of headlines that these products generate. Fentanyl derivatives then are coming in now instead of heroin. We had 5 deaths in 2016 associated with fentanyl derivatives. And it was noted that earlier this year, Northern Ireland issued a public health alert in relation to fentanyl mixed in with heroin. We've seen the emergence of gamma hydroxybutyrate, or GHB, at chemsex parties, and we also have image and performance enhancing drugs such as melanotan and steroids. So there's very different drugs that the addiction services are having to deal with, and very different populations that they're having to work with now. One of the common themes in relation to these new substances is the mental health difficulties that they cause. The slides from the EMCDDA showing the number and range of the new psychoactive substances since 2005, and there's now over 560 substances being tracked by the EMCDDA. The last year in 2015 shows a slight drop, but one of the things we see there is that the increase in the number of opioids and fentanyl drugs, and that would be a big worry. In this country then, as I said, it became a problem because the 2014 Eurobarometer flash poll, which surveyed 13,000 young adults across Europe, identified that 8% of them had used MPS at least once, but the highest consumption was in this country, where 22% of people reported using MPS at least once. 3% in Europe had used MPS in the last year, but the highest use again was in this country, 9% use in the last year. We seem to be very good at hitting the top of various different charts for substance misuse. This is the SPAD study from 2015, and it might be difficult to see. There's some good news in it in relation to 15 and 16-year-old school children. In the tan, it's the Irish figure in relation to the European average in blue, and you see that in terms of alcohol use in the last 30 days and heavy drinking, we are below the EU average now for 15 and 16-year-old school children. However, moving towards the right-hand side of the slide, in relation to lifetime use of inhalants and MPS, we're above the EU average. So there is clearly a problem amongst young people and these substances in Ireland. And the consequences then of new psychoactive substance uses are vast. It seems you can't pick up a medical journal now without reading about a new complication associated with the use of new psychoactive substances. But clearly here, this slide even shows mental disorders, depression, psychosis, anxiety, losing yourself. So mental health difficulties associated with new psychoactive substances is very prominent. So that's the backdrop in terms of mental health difficulties, substance misuse, new psychoactive substances emerging. And maybe from an international perspective, it's interesting to look at how, and from our own perspective, it's interesting to look at how we've dealt with the various issues over the years, mental health, alcohol and drugs. And there's been a number of reports, strategies and bills which have contributed to I suppose the emergence of our dual diagnosis clinical programme. Planning for the future, the ministerial task force, the Rabbit report, as Brian had mentioned, our 2 national strategies, Vision for Change, our national substance misuse strategy, Connecting for Life, and our new strategy. So I'm going to go through some of those today. And I'm going to start to talk to you about Planning for the Future, which was the mental health strategy from 1984, which is supposed to be a strategy for 10 years in relation to mental health services. It ended up being a strategy for 22 years. And times were tough in the 1980s, and as you can see, one of the working group asked their 10-year-old son to draw and design the cover for Planning for the Future. And what this did was it recommended that there would be a comprehensive integrated service for mental health located in the community. And the shift was away from institutional care, which had been the norm in Ireland, to a community-based setting, emphasising the need for close links between psychiatry and community services, and splitting up the services, mental health services, into sectors. There was no mention of comorbidity or dual diagnosis. But there was a large section on alcohol and drug-related problems. It noted that in 1982, 26% of all admissions to psychiatric hospitals were due to alcohol. However, if you took a particular day, only 5% of the residents on that particular day were alcohol related, indicating that there was a large number of short stay admissions to psychiatric hospitals. It noted a doubling in alcohol consumption between 1950 and 1980, and they explained this in the report by the growth in disposable income. It noted a doubling in cirrhosis deaths per 100,000 of the population over the same similar time period. Clear correlation between cirrhotic deaths and alcohol consumption. I also noted within the report 3,000 people were homeless, and they report many of those had alcohol problems. And we forget sometimes that our homeless problem isn't a new problem, it's been there for quite some time. The current figure in relation to homelessness is 7,500, roughly, 7,600. So what it said in relation to alcohol is it recommended a shift away from treatment to prevention. So the approach that the country should take towards alcohol should be based on prevention. Health promotion should be the basis for this. It recommended that there should be a national policy on alcohol consumption and setting up an interdepartmental group of the different government departments. It recommended management should be in the community with major input from the GP and social services, and called for closer liaison between the public and private services for people with alcohol-related problems. That was 1984. Not so sure that that's happened. In terms of the preventative measures in In terms of the preventative measures, pricing of alcohol products, stricter enforcement on drink driving, restrictions on advertising, restrictions on availability, and teacher training programs. That was 1984. We'll talk about that later. In terms of drug problems, it said they weren't in favour of treatment by GPs of drug addicts, so that if drug abuse escalates, psychiatrists should have the major responsibility for dealing with the problem. So that was 84. In 2006, the next report came out, which was a vision for change. As you see, things were better then. You could afford soft focus photography and the very expensive butterfly model. So vision for change was supposed to build for the future, build on planning for the future and follow up. But in terms of addiction, what it said was that addiction now lies outside the mental health system and now completely in primary care. So completely different from the 1984 situation where it says GPs shouldn't be allowed to deal with drug addicts. Now GPs are the only ones who can deal with substance misuse problems. And again, addiction merited 3.5 pages out of a 284-page report compared to a chapter in 1984. There was an expert group set up to feed into this. I was on the expert group, and it's the only expert group where not only were our recommendations ignored, and you get used to that, but they were actually contraindicated in the final report. So since then, we saw that there's been a significant reduction in the number of alcohol-related diagnosis admissions to psychiatric hospitals. However, the harm from drinking in our country continues to grow. 176,999 people in Ireland were dependent drinkers, as identified by the Health Research Board in 2013. 3 deaths per day were from alcohol. 1 in 3 self-harm cases were alcohol-related. And our per capita consumption for 2016 indicates that in all categories of alcohol, we've increased consumption once again. So we've had a couple of national drug strategies over that period of time. And they developed in response to a significant problem associated with injecting heroin use. This was because it was the number one issue on the doorstep for politicians. We had increased numbers presenting bloodborne viruses, and significant money was put into drug services very quickly with no investment in alcohol services. We set up regional drug task forces. Harm reduction was first mentioned in the 2009 strategy. But then we had an economic downturn and investments reduced. This was the steering group report for a national substance misuse strategy. I never liked this. It was a bit shadowy, this report. It looked like something from a Stephen King novel. Maybe Brian designed this, I don't know. But this was the first report to address alcohol within the overall substance misuse problem. It highlighted the inconsistencies in vision for change and it recommended an integrated approach. One of the downsides in relation to this was that the drinks industry were at the table during the development of this strategy, and I think a lot of the recommendations that came out of the strategy were watered down in that regard. But again, no resources were available for alcohol development. Connecting for Life is our national strategy to reduce suicide from 2015 to 2020. And while our overall suicide rate isn't high by European standards, in fact it was the 11th lowest of the 31 countries reporting, amongst young people between age 15 to 19, we had the 6th highest in EU, and alcohol is a factor in half of all completed suicides. Again, note in terms of our self-harm, young female and 1 in 3 self-harms are associated with alcohol. So the strategy recommends that we should prioritise groups for interventions in relation to reduction of suicide and self-harm, and we've been looking specifically at groups who are working with people with drug and alcohol problems. This is our website, askaboutalcohol.ie, and there's a lot of information there in relation to alcohol, suicide and self-harm. This is our current strategy. Brian's alluded to it already. Reducing harm, supporting recovery, a health-led response to drug and alcohol use in Ireland, 2017-2025. It's a bit of a mouthful. I think it's the most politically correct title of any strategy I've ever seen. It ticks all the boxes for everybody. But again, mentions alcohol as being central again to this. Dual diagnosis is specifically mentioned, and it says that we have to support our clinical programme. Very briefly mention the public alcohol bill. It's passing through the Dáil very slowly, more than 600 days, and it talks about restricting availability, restricting price-based promotions, restricting advertising, minimum unit pricing. Where have I heard that before? So in terms of dual diagnosis, what we've done is we've seen these links between mental health, substance misuse becoming more prominent, suicide rates and self-harm. The issue of new psychoactive substances has developed us into producing a response. So in 2016, the HSE Mental Health Division, in conjunction with the College of Psychiatrists, set up a comorbid mental illness and substance misuse programme. We recruited a programme manager in 2017, and a clinical lead commenced work last month. A clinical programme sets up to develop a model of care, setting out national guidelines and care pathways, and support then implementation of best practice. We look to develop joint policies and engage with stakeholders within and outside the HSE. We have to ensure that our service delivery meets the needs of patients. So to date, we've mapped the existing services, and there's very different services right throughout the country. We've commissioned the HRB has commissioned evidence-based research model of care. And so they're doing research on that. We're convening a national working group, and we're working with an advisory group from the College of Psychiatrists. Once the model of care is agreed, we'll support and implement this in terms of training and in terms of monitoring the implementation. And the plan is to have the development of community dual diagnosis teams with access to inpatient drug treatment and rehabilitation units, which is mainstreamed within a 2-year period. The challenge is getting mental health, primary care and acutes to work together. Alcohol treatment has been grossly underfunded since Vision for Change has been published, and resources have not been transferred between divisions. We've got to ensure that all stakeholders are consulted, and we have to try and merge the different models that are operating across the country. So finally, it is an exciting time in terms of the area of dual diagnosis, and the fact that it is currently, or at last, being addressed in a meaningful manner by a clinical programme in terms of an investment. The needs of the individual are now being placed at the core of the service, and we certainly feel that the benefits to family members and carers will become evident as our model of care is developed and established. Thank you.